Good morning to all. I thank KSOS and Dr. Samyukta for this opportunity. My topic of presentation is overview of binocular single vision, and I wish to present this topic under the following headings. It's very interesting to think why we need two eyes in the place of one and what unique advantage does it provide. Binocular single vision is considered to be one of the hallmarks of human race which enable it to have supremacy in the hierarchy of animal kingdom. So vision actually started as single light sensing receptors which evolved into a complex structure of eyeball. As a result of multiple mutations, different species got eyes that serve their unique needs. So a rabbit has a laterally placed eyes, a large binocular field of vision so that they can detect and escape from the predators. Look at the eagle, which has frontally placed eyes, then a large binocular single vision with stereopsis and better visual acuity so they can track and catch the rabbit. So man and primates chose binocular single vision for its advantages of stereopsis, better visual acuity, color vision and contrast sensitivity. This is the classic definition of binocular single vision by Romano and Romano, but a simpler version will be binocular single vision is a type of vision which enables us to fuse slightly dissimilar images from two eyes and perceive it as a single three-dimensional image. BSV is not present at birth and the adult values are obtained by 6 years of age. And we know that we need clear media in the eyes, accurate coordination between two eyes in all cases, and the ability of the brain to fuse these dissimilar images. So before we go into the discussion of binocular single vision, let us understand what are the characteristics of visual stimuli reaching the eye. It has these properties of brightness, form, color, and direction. So what is this direction? If I am looking at an object in front of me, that object will be stimulating a particular point in the retina of both of my eyes. And it goes on to say that when that particular point in the retina is always stimulated, it will be projecting in a particular direction in front of me in the physical space. To understand that, you can press the lateral eyeball at the lateral canthus, then you will see a scotoma in the nasal region, telling you that the visual direction of the temporal element is directed towards the nasal side. So there is a principal visual direction where the fovea is directed and secondary visual direction where the corresponding points are projected. So what are these corresponding points? They are retinal elements of two eyes that share a common subjective visual direction. For example, the fovea of the both eyes are considered to be corresponding points. When they are stimulated, they have a common visual direction and they meet at the point of fixation. Similarly, the temporal elements of the retina correspond with the nasal point and vice versa. There are millions and millions of corresponding points in that. So what is this horopter? Horopter is otherwise called horizon of vision, and it is the locus of all points that are imaged in the corresponding retinal elements for a given distance. So it will seem that objects of the point of horopter will be seen as double. But that's not what is happening. There is an area that is in front and behind the horopter where single vision is possible. And you can see that if objects are seen beyond or behind, there will be diplopia. It can be crossed or uncrossed. So now we understand that the slightly different images falling at the corresponding points of the two eyes are fused into a single image by the property of fusion, which is a motor and a sensory component. Fusion takes place in the brain. It is precise and happening all the time. It's a much underrated facility. And the bottom picture tells you what happens if you don't have a perfect fusion. Then there are factors which will be affecting sensory fusion and motor fusion. Unequal images like refractive error, unclear images like cataract can affect sensory fusion. But motor fusion can be much easily affected by misalignment between eyes and non-strabismic binocular abnormalities, which are the topic of discussion today. Now, briefly moving on to the traits of binocular single vision. If you can see two dissimilar objects simultaneously, it is called simultaneous perception. If you can superimpose two incomplete images and form a single one, it is called fusion. And now stereopsis is the most superior facility of binocular single vision, where horizontally disparate points in the Panem's fusion area are fused, and now you get a depth perception. So we should understand what's the difference between fusion and stereopsis. I think most important will be fusion can occur without stereopsis, but stereopsis is dependent on fusion. And fusion occurs or can occur for both vertical and horizontal corresponding points, while stereopsis is only for the horizontal disparate points. So now, for the completion of sake, I am mentioning the anomalies of binocular single vision. The non-strabismic anomalies will be dealt with in the next session by Dr. Mallika. So we know that diplopia, where one phobia and extrafoveal point is stimulated. Then confusion, here phobia of both eyes are stimulated by different objects. You get an overlap picture. Then there is rivalry, binocular retinal rivalry, that is simultaneous excitation of the corresponding areas by the dissimilar stimuli. This is what you get in binocular rivalry. Then finally, suppression, that is occurs in the immature visual system, where to eliminate diplopia and confusion, which leads on to amblyopia. So I am concluding my talk by saying that binocular single vision anomalies should be detected as early as possible because they can be reversed in plastic period of development, and we need to have a better understanding and mechanisms of binocular single vision for optimal treatment. Thank you.
Thank you, madam, for that excellent overview. Now let me invite Dr. Mallika Harikrishnan, Professor, Government Medical College, Thrissur, to speak to us on an introduction to non-strabismic binocular vision anomalies. Over to you, madam.
Good morning, one and all. Thank you, Dr. Samyukta, for giving me this wonderful opportunity. My topic today is an introduction to non-strabismic binocular vision abnormalities. In the previous era, when man's survival depended upon hunting, fishing and farming, his visual system depended upon very clear distant vision and stereopsis. But in the modern era, when there is changing of his, he is more adapted towards the near vision and this binocular vision, like because he is more dependent upon reading, desk work and computer work. So what happens is that in some people, the visual system is not able to do this function properly either because the tasks lack the stereoscopic cues or the tasks require accurate and sustained accommodation and vergence functioning. So due to this, some people, due to lack of appropriate vergence or accommodative ability, if they try to do near vision tasks, that will result in ocular discomfort or fatigue. So what is binocular vision anomalies? Binocular vision anomalies are vision disorders that affect an individual's ability to maintain focus on a single object with both eyes. They also include disorders that prevent the brain from fusing the images from the two eyes into a single vision. So what is actually vision? It is not just reading 6 by 6. It is a process of deriving meaning from what is seen. And it includes a number of processes that happen in a hierarchical manner at the neuronal level. These are, first one is the fixation. You have to fix at an object. Second one is the monocular accommodation to see an object clearly. And the third one to integrate the processes in both eyes to have a single clear vision, that is vergence. And the fourth one is the oculomotor function, which helps us to track an object you are fixing. This is a representation of conceptualization of vision. This is represented as a pyramid The base of the pyramid is constituted by comprehensive assessment of eye and visual system, where you assess the eye as such, anterior segment, posterior segment examination, you do the refraction and all. And the second thing is the visual efficiency or binocularity. Third one is the oculomotor testing. And fourth one is the perceptual assessment or visual information processing. What is important is that you should concentrate on the base of the pyramid. Unless you do proper assessment of the appropriate refraction testing and correction, unless you do the proper correction, you are not doing any justice to the rest of the pyramid. So the question comes, is there any need of binocular vision care? Yes. Because we are not dealing with any Cyclops or Mr. Cyclops or Octopus. We are dealing with a man with two eyes, and the two processes happening in the both eyes has to be integrated to get a single vision. I would like to share a few recent papers. This is a paper showing the prevalence of non-strabismic anomalies of binocular vision conducted by Rizwana et al. And it shows that the prevalence of NSBVA among children in the age group of 7 to 17 years is nearly 30 to 30.8%, where the convergence insufficiency is 16% and accommodative infacility about 11%. If you check the global data, it is almost similar or even more than this. Gives you the inference that it is not occurring, it is not confined to one part of the world. So what about the adults? Here also thing is not different. About 56% of asthenopic symptoms can be attributed to binocular vision abnormalities. This is another paper where they decided to what is the ocular and visual discomfort associated with smartphones, tablet and computers. And they found that there is increased lag of and decreased amplitude of accommodation with handheld devices, and the smartphones and tablets reduce the functional convergence. So if you look at the digital eye strain also, 90% of the digital device users also experience digital eye strain attributed to uncorrected refractive error or accommodative and convergence anomalies. So who are the people we are targeting at? It may be school children, an IT personnel, a sport personnel, an accountant, or even it may be you and me. Everybody is in neuropathy, myasthenia gravis, etc. And for the as causes of accommodative dysfunction, you can have a few drugs which can cause bilateral NSBVA abnormalities, unilateral local eye diseases, and general diseases in adults like encephalitis, syphilis, trigeminal neuralgia, myasthenia gravis, etc. What is important is that if some people will present with acute onset of NSBVA abnormalities, you have to remember all these conditions. This is a drug list which can cause accommodative dysfunction. You can keep it in your clinic. And this is the suggested questionnaire to elicit the NSBVA abnormality. So what is important is that binocular vision abnormalities are common in our daily practice. The testing to be included in the primary eye care system, and you have to ask the right case questions, and you have to evaluate the patients using right tests and make the diagnosis. Thank you so much.
Thank you, madam, for that excellent talk. Now let me invite our Chief Instructor, Dr. Samyukta Sadasivan, to talk to us on evaluation and diagnostic workup of non-strabismic binocular vision anomalies. Over to you, Dr. Samyukta.
Good morning, one and all. With due reverence to all our mentors, I start off with evaluation and diagnostic workup of non-strabismic binocular vision anomalies. So the two limbs of binocular vision assessment are accommodation and vergence testing. We begin with vision and accurate refraction, followed by binocular balancing, and then we proceed to the proper orthoptic assessment, under which we include accommodative procedures, vergence procedures, and oculomotor procedures. So visual acuity, uniocular and binocular, both for distance and near, need to be assessed as we get clues to whatever we are dealing with from this first stage itself. These are the diffraction procedures in binocular testing, binocular balancing methods, Borish delayed testing, sudden unfogging, dynamic and cycloplegic refraction. Orthoptic assessment, we start off with accommodative procedures. Near point of accommodation or NPA refers to the closest point at which represents the limit of accommodation at near. This represents the maximum amount of accommodation that the eyes can exert monocularly and binocularly. So as you see, the patient's attention is directed to the row of letters better than the best corrected visual acuity on the RAF rule. He is instructed to keep the letters clear. And the chart is moved closer and the patient is asked to report when the letters become blurred. The distance from the chart to the patient's spectacle frame plane in centimeters is the measured NPA, which can be directly read off from the RAF rule. Now this linear distance, when converted to diopters, will give you the amplitude of accommodation. So these are the average expected amplitudes, Hofstadter's minimum, average and maximum with regard to age. Now we go ahead with accommodative response, which is the assessment of accommodative status during near visual activities, based on the assumption that at a distance of 40 centimeters, the accommodative demand is 2.5 diopters. If the eyes accommodate less than the demand, you call it lag of accommodation, and the opposite is lead of accommodation. So we perform this monocular method of retinoscopy to assess your accommodative response. Patient wears her spectacle correction, best corrected spectacle correction for both near and distance, and the test is performed under binocular viewing conditions. She is instructed to focus at a smallest row of letters read easily at a working distance of 40 centimeters, and now you perform your retinoscopy. Utilize the reflex. If it is a with motion, you add plus lenses. If it is an against motion, you add minus lenses. And the lens power which is required to attain neutrality is noted. The normal expected accommodative response is a lag of accommodation at near of about 0.25 to plus 0.75 diopters. Then you have the relative accommodation measurements, which is an estimate of the range of accommodation from stimulus to relaxation at a fixed distance. Addition of plus lenses in negative relative accommodation relaxes accommodation. So this will stimulate divergence due to the AC by A cross link. To maintain clear single binocular vision, now the eyes must converge. So inadequate fusional convergence can reduce the end point of negative relative accommodation. Vice versa, in addition of minus lenses when you calculate positive relative accommodation. This is the NRA-PRA testing procedure. Patient wears the habitual correction. N6 target at 40 centimeters is focused at. And plus lenses are added binocularly in plus 0.25 dSP steps till the patient reports the first instance of sustained blur. That is the value of negative relative accommodation. Same procedure repeated with negative lenses. The first persistent blur is the positive relative accommodation. These are the normal values for NRA-PRA normal accommodative response. For assessing the dynamics of accommodation, you have to do the accommodative facility testing using accommodative flippers. So this is performed using 2 diopter lens flipper, which the patient holds close to the eyes, plus lens first, and on clearing the target, it is flipped to the minus side. The number of flips made are noted. This is a testing procedure, and these are the targets given. Patient again wears the habitual correction, standard testing with 2 diopter accommodative flippers at 40 centimeter testing distance. A full cycle includes both plus and minus lenses. Number of flips made per minute is recorded. Now we move on to the vergence procedures. So we do Fourier measurements, and this is followed by vergence amplitude assessment, and then vergence flippers are used to test the vergence facility. So near point of convergence, the test measures the patient's ability to converge the eyes while maintaining fusion. The patient maintains habitual correction, and the accommodative target is held at 50 centimeters distance on the RAF rule. The target is moved closer, observing the patient's eyes until the patient reports doubling of the target, and the examiner should observe for any loss of fixation in one eye. The distance at which the target doubles is the break point. At that time, you recede the target a little backwards, and the distance at which the patient's deviated eye regains fixation is noted. So that is the recovery point. Normal NPC is 8 centimeters. So for fusional vergence range assessment, we make use of the step vergence method and the jump vergence method. Measures the patient's amplitude of fusional vergence for both distance and near. So step vergence is assessed using the prism bar. A vertical target is shown at near and at 6 meter distance. Prism bar is placed in front of one eye, base in first, and negative fusional vergence is tested first. Blur is when the target is not clear, break when the target doubles, and recovery when the target becomes single. All the values are recorded in prism diopters. Fusional vergence examination, please remember the order of examination: measure heterophoria first, followed by divergence amplitudes, and then we move on to convergence amplitudes assessment. Jump vergence, we have the vergence flipper which tests the dynamics of vergence. Habitual correction is 1, testing distance of 40 centimeters. Standard flippers, 12 prism diopter base out and 3 prism diopter base in are used. The patient is instructed to hold the flipper close to the eyes, base in first, and flip is made when the print becomes single and clear. The number of flips made per minute is noted. So these are the normal values which we expect at the end of our evaluation. This should be followed by ocular motor testing because children with reading difficulties can have poor saccades and pursuits as well. Do not forget AC by A ratio. The routinely employed method is lens gradient method, where deviation without lens minus deviation with the lens divided by lens power and diopters. So these are the potential components of the diagnostic evaluation for accommodative and vergence dysfunction. Thank you very much.
Thank you, Dr. Samyukta, for that very interesting talk. Good morning, everybody. First of all, let me thank KSOS and Dr. Samyukta for giving me this opportunity. Today, I will be discussing about the disorders of accommodation. With an increase in demand for the near vision task associated with today's modern lifestyle and along with the COVID pandemic, the disorders of accommodation have now become the new pandemic. So which are the patients in whom we have to suspect disorders of accommodation? We suspect such conditions in patients with no significant refractive error and no significant phoria, but presenting to you with complaints of eye strain, including discomfort and strain associated with near task, blurred near vision, fatigue associated with near task, and difficulty with attention and concentration while reading. So in these patients, we do a battery of tests for accommodation, which was discussed in detail by Dr. Samyukta, which includes the assessment of near point of accommodation, the normal accommodative response assessment by using the MEM retinoscopy, the relative accommodation assessment, and the accommodative facility testing. So, first we test for the tests which require the stimulation of accommodation, like using the minus lenses, and if they are affected, that means the patient has accommodative insufficiency. If the test probing the ability to relax the accommodation, especially using the plus lenses, are problematic, then we have to think in terms of accommodative excess. And if both the tests, those that require the stimulation of accommodation as well as the relaxation of accommodation, are affected, then it is accommodative infacility. So broadly, the disorders of accommodation can be classified into 4 categories. The first one being accommodative insufficiency. The second one is ill-sustained accommodation. You have accommodative excess and accommodative infacility. Now coming to the first one, that is accommodative insufficiency, it is a condition where the patient has difficulty in stimulating the accommodation. It can also be called as premature presbyopia, and latent hyperopia and overcorrected myopia can present with eye strain. Before we jump into the NSBVA management, we need to rule out certain mimickers which can present with accommodative insufficiency, especially drugs like alcohol, cycloplegics, antihistamines. There are a group of diseases in adults and children which can produce accommodative insufficiency, and keep a watch on neurophthalmic conditions which can also cause these problems. So that definitely need to be ruled out before we go into the definitive test for these. For accommodative insufficiency, the definitive sign would be a reduced amplitude of accommodation. As she had well described, you check it with the near point of accommodation assessment with the RF rule, and you convert it into the amplitudes. And if it is 2 diopters less than the Hofstadter's minimum amplitude, which is calculated as 15 minus 0.25 into age, then it is accommodative insufficiency. And the patient also has difficulty in clearing -2 with monocular and binocular accommodative facility testing, and when you check for the accommodative response, there is a high MEM retinoscopy findings. The complementary signs would include a low positive relative accommodation and a high negative relative accommodation. Ill-sustained accommodation actually is a subclassification of accommodative insufficiency. It can also be termed as accommodative fatigue, where when you check for the accommodative amplitude, it will be normal in the beginning, but when you go on checking, you find that there is a deterioration in the accommodative amplitude. So repeat measurements of accommodative amplitude is mandatory for the diagnosis of ill-sustained accommodation. Now, how do we go about the treatment of these two conditions? Basically, if there is any emmetropia, optical correction of emmetropia should be done, and that should be followed by added lens power therapy. And then you go into vision therapy, which can be either in the office-based or a home-based. Now, what is the amount of the plus lens that you need to prescribe for these patients? There are two options. Either you can take the arithmetic average of the positive and negative relative accommodation and prescribe that, or the second option is you can do the accommodative response assessment, that is the MEM retinoscopy, and from that value you can subtract the normal value of 0.5 and you can give the classes. Vision therapy has basically three steps. The first one is to normalize the accommodative amplitude. The second one is to incorporate the speed and response into accommodation responses, and the third one is to integrate it. The third type of accommodative problem is accommodative infacility, and in this case the patient has difficulty in shifting focus from distance to near. So it is the amplitude will be normal in this particular condition, but the problem is with the dynamics of accommodation, that is the latency and speed of accommodation would be abnormal. The symptoms, in addition to the usual eye strain problems, the patient will have difficulty changing the focus from distance to near and from near to distance. In this particular case also, it is mandatory that you rule out certain mimickers which can produce accommodative insufficiency in facility, like drugs, some general diseases like anemia, diabetes, encephalitis in adults, anemia, mumps and measles in children, and neurophthalmic cases. Once they have been ruled out, you have to confirm this by ensuring that the patient has difficulty in clearing both plus and minus lenses by using the accommodative flippers. So the definitive sign is difficulty in clearing -2 and +2 with monocular accommodative facility testing, and complementary signs would include a low negative relative accommodation and positive relative accommodation, and difficulty clearing minus and plus with binocular testing also, and a secondary fusional problem can also be associated. The treatment of accommodative infacility would be vision therapy. Now we come to the fourth and the final one, that is accommodative excess. In this particular condition, the accommodative response exceeds the accommodative stimulus. An uncorrected refractive error and hyperopia can sometimes precipitate this, and ciliary spasm sometimes causes egress in myopia, that is called pseudomyopia. Sometimes a dramatic presentation with intermittent attacks of accommodative convergence and meiosis can occur, that is called spasm of the near reflex. In this particular case also, you see that there are a group of systemic conditions which can mimic this, and they need to be definitely ruled out before you go into the definitive diagnosis. So the definitive signs in this particular condition are the variable visual acuity findings, variable static retinoscopy and subjective refraction, and when you do the accommodative response assessment by using the MEM retinoscopy, you find that there is a low value of MEM retinoscopy, and the patient has difficulty with plus lenses when you are testing the accommodative facility. The complementary signs would be difficulty clearing plus with binocular accommodative facility, reduced negative relative accommodation, reduced negative fusional divergences, and esophoria and myotic pupil. The treatment is by using vision therapy. So what are the vision therapy options available? You can have the common ones which are very familiar, like this is a heart chart where the patient has to look at a near target and then a distant target intermittently so as to stimulate and relax the accommodation. Accommodative flippers, which were used for diagnostic purpose, can also be used for therapeutic purpose for stimulating accommodation and relaxing them. The other tests would include a red rock test, accommodative rock cards, accommodative hoping cards, loose lens rock. So these are the specific tests which can be done for the accommodative problems. Now to sum up, in accommodative insufficiency, patient has difficulty clearing minus lenses, and treatment is added lens power and vision therapy. In infacility, the patient has difficulty with minus and plus lenses, and treatment is vision therapy. And in accommodative excess, the patient has difficulty with plus lenses, and the treatment is vision therapy. Thank you for your patient listening. Thank you.
Thank you very much, Sudha, for that wonderful session. Now inviting Dr. Ashwati P. to have her session on convergence anomalies.
Good morning all. Thank you KSOS and Dr. Samyukta for this wonderful opportunity. My topic today will be disorders of vergence. The classification of vergence disorder is actually a modification of the original Duane's classification by Vick, and this is based mainly on two variables. One is the AC by A ratio and the other one is the distance phoria. So accordingly, we have three major classes: those with low AC by A ratio, those with normal AC by A ratio, those with high AC by A ratio, and each of them is further subdivided into three based on the distance phoria. In addition to these horizontal heterophoria, we also have vertical anomalies. The patients of Vergence anomalies usually present with aesthetic symptoms, and that would be more significant during prolonged near work like reading. But if the patient has significant phoria in the distance, then the blood vision and the double vision would be prevalent during distance vision also. The symptoms are generally worse during the end of the day, and one specific symptom that needs mention is the abnormal sensitivity to the light that would be complained of by patients with divergence excess, that they often has to close one eye when exposed to bright light. To elicit a proper history, we have various instruments like the Convergence Insufficiency Symptom Survey and the College of Optometrists Quality of Life Outcome Assessment. These grade the symptoms in terms of frequency and severity. Coming to the diagnostic evaluation, first we have to determine the refractive error and then assess the size and direction of the phoria. You can do the cover test, AC by A ratio, Vergence assessment, NPC, and fixation disparity assessment. The normal AC by A ratio we expect is around 4:1 with a standard deviation of plus or minus 2. Now, once the patient presents with the compatible symptoms and the visual acuity, refraction, and eye health examination is normal, first thing we have to assess is the distance phoria. Now, suppose there is an exophoria, we have to assess the positive fusional Vergence group of data. If that is found to be low, you assess the AC by A ratio and then compare the distance and near phoria. If the distance phoria is more than near phoria, what we have is a divergence excess. If both are equal, we have a basic exophoria, and if the near phoria is greater than that of distance, we have a convergence insufficiency. Similarly, if the distance phoria is an ESO, we assess the negative fusional Vergence group of data. If that is low, again we assess the AC by A ratio and compare the distance and near phoria. If the distance phoria is greater, we have a divergence insufficiency. If both are equal, we have a basic esophoria. And if the near phoria is greater than the distance, then we have a convergence excess. If there is no significant phoria at distance or near, we have to consider anomalies of accommodation. Now, some people do not have significant phoria and their accommodative findings are also normal. It is then that we have to consider fusional Vergence dysfunction as an important differential diagnosis. So these are the major types of Vergence anomalies and the definitive signs to diagnose these conditions. Convergence insufficiency is the most common one seen among the Vergence insufficiencies. And to take care that the Vergence insufficiency may have normal AC by A ratio, there is no phoria, but the fusional Vergence amplitude might be restricted both in the positive and negative direction. Sometimes even the amplitudes will be normal and just the Vergence facility will be abnormal. Now, before making a final diagnosis, we have to rule out more significant, more serious conditions that may mimic these anomalies. Coming to the management, first we have to do our optical correction of emmetropia. Then added lens power, prism, occlusion, vision therapy and surgery are the other alternatives. We have to correct uncorrected refractive error because an uncorrected refractive error will result in disorders of accommodation, fusional Vergence and create an imbalance between the two eyes. So any significant amount of refractive error has to be corrected. The decision as to whether to use added lens power depends on the AC by A ratio. If the AC by A ratio is high, then added lens power will have an advantage. If it is low, it might not have an advantage. And if it is normal, the other factors mentioned here also have to be taken into consideration before you decide on the treatment option. Convergence excess and basic esophoria respond well to added plus lens and high exophoria and divergence excess to minus lens. Prisms are useful in decreasing the demand on fusional Vergence, and they can be prescribed as temporary measure till vision therapy takes its effect or in order to eliminate the use of vision therapy. ESO deviations respond well to prism than exo deviations. They are most effective for divergence insufficiency, basic esophoria and vertical heterophorias. Vision therapy was the treatment of choice for convergence insufficiency, divergence excess, fusional Vergence dysfunction and basic exophoria. And exophorias basically respond well to vision therapy as compared to ESO. Now, our aim in vision therapy is to re-establish an automated, effortless Vergence response under any stimulus condition. The patient should be freely able to converge and diverge from any distance from 5 cm to 6 meters. In the first phase, we normalize the Vergence amplitudes. In the second phase, we increase the speed of response to the Vergence stimuli. And in the third phase, jump our Vergence stimuli are used. The most inexpensive, we have a lot of instruments for vision therapy, but dropstring CAD card and eccentric circle card are the most inexpensive and feasible options that can be used. Surgery is not much recommended in case of non-strabismic disorders, but if the magnitude of horizontal deviation exceeds 30 prism and the patient is not comfortable with the other non-surgical measures, surgery might still have a role. So these are the primary treatment options. We may have to use a lot of treatment options together in combination, but the primary treatment would be these in each of these conditions. In convergence insufficiency, divergence excess, basic exophoria and fusional vergence dysfunction, we have vision therapy as the primary option. In divergence insufficiency and basic esophoria, base out prism is the first choice. Vertical phoria, it is the vertical prism. And for convergence excess, we have added lens as the first option. So that would conclude. Thank you.
Thank you, Dr. Ashwati, for that. Now it's a moment of great pleasure for me to invite Strabismic Services and in charge of low vision services, Arvind Eye Hospital, Tirunelveli. Mentor to umpteen students both inside and outside the country, I would describe Dr. Fatima A as an elegant blend of being an authority in the subject and an embodiment of powerful silence and humility which every student in Arvind would vouchsafe. Thank you for being with us, madam. Over to you.
Very good morning to you all. Thank you, Dr. Samyukta, for this wonderful opportunity and KSOS. Till now we have listened to excellent talks about all the aspects of NSBVA. So we will go into different case scenarios. First of all, I like to emphasize the vergence disorder and accommodation disorder has a close link, everybody knows. One can induce another, one can occur as a compensation for another disorder, or both even associates, like coexist. So we will see, the first one is I like to deal with this convergence insufficiency. As Dr. Mallika mentioned, convergence insufficiency is the commonest in SBSVA. So in this case, one 15-year-old Ria, actually these are not real patient's name, I have changed it, complaining of eye strain after 10 minutes of reading, 15-year 10th grade student. Imagine the distress the patient has. She had the the findings suggestive of convergence insufficiency. So if we stop up to it, we will not be able to find out this data. When we worked upon the accommodation status of the patient, we were able to find out she had accommodation insufficiency too, because he was able to not able to stimulate accommodation, lack of accommodation, so on. So what is here is the primary disorder is accommodation dysfunction, insufficiency, which leads on to which source, because of that the amount of near exophoria increases and the positive fusion vergence value decreases. It is not actual convergence insufficiency, it is pseudo. This patient needed an instant relief. This patient will not wait for vision therapy and all. Particularly 10th and 12th grade patient, we cannot convince them for office-based therapy. In Tamil Nadu, I hope that may be true in Kerala also, because the reading is their primary motto. So near add, minimum add was given to the patient and along with vision therapy. Vision therapy should always include positive fusional vergence strengthening also. Even though it is pseudo-convergence insufficiency, we have seen patient coming back with double vision, decompensated phoria. And also we have informed her that she may need prism in future if she doesn't do accommodation, if she doesn't do exercise properly. One-way safeguarding, happily we can prescribe if the patient comes back with decompensated phoria. So few words about accommodation insufficiency. Like for all other conditions, we have to treat small, even whatever small refractive error, whether even if it is minus cylinder, we have to give. And if there is associated esophoria, we can comfortably prescribe NIRAD. If it is associated exophoria, we will add, we have to add with fusion exercise. And young children, we can really encourage them to undergo office-based vision therapy and see improvement in accommodation. Unlike fusion insufficiency, accommodative insufficiency, does not really respond well to vision therapy. It needs more dedication and involvement from the patient side. So here comes the case 2, where 11-year-old Biju complaining of eye strain with reading, again same complaint. And always we have to include the systemic illness history and systemic medicine history, as the previous speaker pointed out, to rule out the other systemic illness. And here if we see, there is the findings of convergence insufficiency. But if you look at the accommodation excess data, the NPA is normal. If you stop up to this, you will not find out these data. So the facility testing at least should be included even in high volume OPD. So particularly monocular accommodation facility. Binocular accommodation facility will be very much influenced by the Vergen's disorder. If Vergen's disorder is there, you will naturally get binocular accommodation facility values also will be affected. So here MAF also shows 0 and fails to relax and findings of accommodation excess. And if you look at the refractive error, it is minus before in dynamic and plus in cycloplegic, so pseudomyopia-like condition. So convergence insufficiency with accommodation excess. So what has happened here is accommodation excess has occurred as a matter of compensation. To compensate the insufficiency, accommodative convergence has come into place. So the patient has over-accommodated and ended up in accommodation excess. So we have to concentrate both the aspects in our vision therapy. Patient underwent 2 weeks vision therapy and recovered well. So up to now what we have learned is convergence in CI can be associated with normal accommodation or excess as a compensatory mechanism. If it is with weakness, it may be of pseudo-convergence insufficiency. So coming to few excess cases, because nowadays we see more excess cases in this digital usage era. Case 1, 13 years, 8th grade. Here a typical case of variable reflex, more minus in dynamic and in cycloplegic very less minus. And patient was diagnosed to have pseudomyopia. Patient was being treated elsewhere with the progressive addition lens and plus 3 diopter. Even then she was somehow not convinced and comfortable with the treatment. So she stopped the treatment and came to us. Actually she visited Madurai Aravind. So where they treated her with office-based exercise, modified Boris delayed subjective testing technique for 8 sittings. The symptoms resolved completely. So patient was very happy. I like to thank for this Dr. Shetty sir, Chief of Pediatric, and Ms. Janani, optometrist in Madurai Aravind Hospital, for sharing this success story to us, so that we have also started this technique in our vision therapy. Coming to, let me describe the technique in little later in my slides, and coming to second case of accommodation excess. This child, 9-year-old, presented to us with intermittent inward squinting. So similar episodes were there before, and there was no history of prolonged mobile phone usage. Usually it will be associated, but here no usage, no mobile phone usage. Refraction was completely normal. And here if you see the data, the patient at once, when you saw the target, the patient will go for esotropia, that too large angle, 45% diopter esotropia. And if we look at the accommodation values, it is towards excess, minus 5.5, and high lead of accommodation. So what is here? Here with cycloplegic refraction, we were able to note down that there was +1 diopter refractive correction. So we prescribed him with the correction and vision therapy. And 2 weeks later, but he came back. So this time we have engaged him in office-based therapy for 12 sittings. With 12 sittings he recovered very well, but again to our surprise he came back within 1 week that the condition recurred. That time the mother revealed to us. Earlier we were probing her any precipitating factor like that, the history we were asking, but we were not able to elicit from her. But this time she was able to pinpoint that whenever that her husband is a drunkard, so that fighting argument goes on, he goes into kind of such distress, stress, and manifest this. So definitely the important causative factor has to be addressed. So we arranged for parents counseling, and also nowadays we see many patients, many children who are under psychiatry treatment showing accommodation excess. So that part has to be considered, and a proper referral to psychiatrist in case whenever necessary has to be done. So what is modified Boris delayed technique we follow? It includes 2 phases. It is clearly described in this article by LVPI. So in the distance phase, we make the patient to wear strong fogging lens. That is, we include the normal NRA value plus 2.5 plus cycloplegic refraction value. This patient, for him it is 3.5. So we put 3.5 on both eyes and ask him to read a storybook for 30 minutes. Initially, excess patient will read keeping the book close to them. We will encourage them to push the book backward, longer as far as possible, at least 30 centimeter, 35 centimeter at the end of 30 minutes. So by the time the patient will relax the accommodation, and then we will make defogging for distance, 6/9 target, and we slowly defog with minus lens. So the patient is relaxed, patient's accommodation is relaxed for distance. Now the near face is done. Near face is nothing but like performing NRA testing monocularly. Since because we does monocular, the fusional loop is removed, we concentrate more and more in accommodation part. What we do is this accommodation phase, we gradually add plus lens till the patient relax completely, then we can induce accommodation. Maybe inducing accommodation we can withhold for initial few days. We can aim only relaxation in the initial days, then we can move on to stimulation also. So similar procedure is done in other eye. And here comes our PG NEET aspirant. You can imagine the status of the patient's eyes. So his complaint is double vision for past 2 weeks, particularly for distance, and onset was associated with fever. MRI taken was normal, and refraction absolutely, dynamic refraction was fine. So when we worked up with binocular status, we were able to find out distance esophoria 4 prism diopter. So kind of divergence insufficiency. But when we look into the accommodation data, he showed excess. Though MEM value is normal, MEM value also depends upon the person who performs. It should be done in a swift manner, fastly. The procedure should be correct. Otherwise the value. So we have to correlate, always we have to correlate more than one value to conclude the diagnosis. When we did cycloplegic refraction, we were able to pick some uncorrected hypermetropia. So what we did is we gave him that hypermetropic glasses and advised him exercise regarding accommodation excess and for divergence. To our surprise, his symptoms relieved, and also importantly the counseling about the need for break and not to use mobile phone for reading, everything has to be emphasized. Here this case says how much important is the uncorrected refractive error treatment. So what we have learned here is the very first case was accommodation excess with just pseudomyopia. Second case was accommodation excess with intermittent esotropia. And the third case, the second patient, then when he came for later visit, he presented to us with all the findings. And that NEET patient had uncorrected refractive error, and CI patient also can show accommodation excess. So counseling, nowadays there is a mad behavior among parents regarding too many coaching classes, and from school too many homework, and from students themselves prolonged mobile phone watching, sleep deprivation, and apart from that there is many incidents of psychological stress. All have to be addressed for holistic recovery. Here is another interesting case of 13-year-old where intermittent diplopia past 2 days. As mentioned by Dr. Malika, acute presentation we should always be take into concern. BSVA will not present with acute symptoms, but here the patient was a doctor's daughter. So we thought, okay, they were anxious, they brought so quickly. What the workup showed, the refraction showed little hyperopic thing. Again here, near exophoria and distal esophoria, that is divergence insufficiency. And look at the accommodation data, everything is fine. Even the NRA is also high, we are strange. Extraocular movements full. But our ocular examination was not complete. Small people were not able to see the fundus. We were insisting for dilating fundus, but next day the patient had half-yearly term exam. Parents were hesitating. So what we did is, we asked for evaluation because there is some foria difference. Luckily, our optometrist brought out incompetence in the foria. That too, fixing right and left were different. So now we strongly suggested either dilatation or MRI imaging has to be done. Then we found out this papilledema in that patient. and luckily it turned out to be pseudotumor cerebri and treated and recovered in 2-3 weeks. So the point here is we should never compromise complete ocular examination and never label the patient without ruling out ocular cause and systemic cause and say NSBVA, because there is a high chance to miss important things. And here is a case I wanted to show, Duane's retraction syndrome. Again, fusion problem when she has developed accommodative demand as she grows older. But here we can very well note the patient is not able to bring the eyes into the center because of the co-contraction. One eye is not at all able to converge inside. Here there is no role for fusion exercise treatment, so we straight away suggested her 4-prism adapter basin. So to conclude, thorough history taking, ocular and systemic, complete ocular examination, detailed workup, dedicated vision therapy is important for appropriate diagnosis and management of NSBVA. Thank you very much. Thank you very much.
Thank you so much, madam. That was a very enlightening talk. Now let me request Dr. Padmaja madam to present a token of appreciation to Dr. Fatima ma'am.